Good evening and welcome to AMDA COVID Grand Rounds, Pearls from your colleagues. I'm Sabine von Price-Friedman with the Washington State AMDA and your host today. Pearls from your colleague is an ongoing peer discussion on COVID-19 in the post-acute and long-term care space. We know our patients and our care teams have some very specific needs, and we want to make sure that we learn what we can about what serves them best through data and practice. Today, we are addressing a topic that we are all very familiar with. For me, certainly, this has become very personal. The emotional toll of caring for our patients during COVID, how it has affected our staff, and importantly, what we as medical directors, attending physicians, and team members can do to recognize it and to support each other. We want to make this an interactive discussion as usual, and we really encourage you to use your chat function. That way it really does become a peer-to-peer discussion. Starting in late February, we were blindsided by this massive outbreak in what felt like out of nowhere. In the early phases of the outbreak, despite our best efforts, many of us saw the disease ravaging through our facilities with many patients falling ill and dying. We all tried to respond quickly, but were severely hampered by lack of resources. As we were trying to understand the disease and figure out the best way to stop the spread, we had to watch as our staff had to make do with crisis-level PPE, being reduced to wearing raincoats, makeshift eye protections, or even trash bags. And I personally felt quite bad and guilty about that. Many staff became ill themselves, and that was hard to watch. Some even severely, some have died. Many feared for their families. That was then. Now we're in a different phase of the pandemic. As PPE is more available and we have learned the beneficial effects of social distancing and strict adherence to wearing masks and face shields at all times, disease activity has become more sporadic, less explosive, but remains a constant threat. Much of what makes our work so gratifying, the close contact with patients, the healing touch, the kind word and laughter, have become restricted through masks, face shields, and other PPE, and patients not mingling with staff anymore. In fact, patients can't hear and recognize the staff as well. PPE gets hot and uncomfortable, and staff have to wear it all the time. They can't socialize as well with each other anymore. To start us off, here are a few areas we want to address in tonight's webinar. How can we recognize and approach the staff trauma that an outbreak has caused in our facilities? How can we as medical directors and physician leaders help staff deal with anxiety for themselves, their families, and potentially their livelihood caused by COVID? And how do we support staff through ongoing restrictions caused by social distancing and PPE? We are grateful to have three peers to discuss this important area with us. Dr. Arif Nazir, our immediate past president and CMO of Signature Healthcare, has been on the forefront in our industry of staff support. Kathy Owens is a master's level nurse and ARNP, and I've had the good fortune to work with her as my partner at Avalon Healthcare, where she's chief clinical officer. She's a strong and empathic leader of our large nursing team. Dr. Leah Watson, you can't see her today, but she will talk. She's a very eloquent talker, is a geriatric psychiatrist and consultant to the long-term care workforce on issues of behavioral health, psychopharmacology, and provider well-being. Let's start with a poll. Erin, pull up the first poll. You've had an outbreak of COVID-19 in your facility. How does this affect the mental health of your staff? I don't know. They are dealing well. I'm concerned. We have recognized and approached staff trauma successfully. And the poll is now open. And I can't see how you guys are voting, so I'm just as eager to see the results. And Aaron, after about a minute, we're going to share the results. Okay. I'm not surprised by the most common question, or the most common response here is, I'm concerned about trauma, but I don't know how to help. I think that is probably some of us, or all of us, are feeling part of that. So, Dr. Watson, let's start off with you. How do we recognize and respond best to staff trauma from COVID outbreaks?
Thank you, Sabine, and thanks to AMDA for carrying on with these wonderful ways to connect with each other. And that's actually going to be how I think I first respond to this as a psychiatrist and an expert in all these areas. I think it's very ironic to me about what really matters at times like this. And it's really about being human. You don't have to have any extra special training to know how to check on each other and to find times to connect. And I think the nature of this pandemic is that we are all suffering from it, every single one of us. And some of us were already quite vulnerable as this pandemic began. So the main paradigm I like to think about when trying to figure out how to take care of each other is actually the trauma-informed care paradigm, which is that what we all need most is safety. We need to know what's happening. We need to have clear and trustworthy communication. And that comes from our leadership that engage in frequent communication and a central access point of communication. It comes from having your voice listened to and for feeling like others care for you and that you don't have to ask for help, which we know is quite stigmatizing actually. So one of the leaders that I work with locally has now made it a habit to actually insist that her staff, this is a nurse leader, to insist that her frontline staff take a 10-minute break every couple of hours, whether they want one or not. Finding ways to communicate. When you notice that your peers or coworkers are starting to get numb and sort of check out, those are classic signs of a trauma response. Withdrawal. And of course, we can't see people's faces. We can't see their facial expressions. We can't touch people and give them a squeeze on the shoulder and tell them to hang in there for the rest of the day. So all of these things really involve connection. And I don't want to keep talking, but I'll tell you one thing that happened to me today that I think is relevant. So I consult with lots and lots of providers and help them take care of the patient. So I don't see patients directly as much as I help support providers. And I've been talking to people very frequently who have been calling to check in about their own sadness. And one of the issues we've been dealing with is now that we're in the marathon and not the sprint, our residents are really suffering from loneliness and isolation and deconditioning and depression. So I've had a huge increase in requests to increase people's antidepressants this week. So I just got off the phone with a nurse practitioner who said, I know what she really needs is to see her family and to get back to activities, but is it okay to go up on her sertraline anyway? And so we talked about the pros and cons of it. And from a clinical standpoint, I'm not sure medications are going to do much to help. I think we really need to start liberalizing our visitation policies and to be very creative and selective about ways to engage people. But it dawned on me very quickly that we are also suffering from loneliness and social isolation. And some of us are feeling depressed. And I just had this aha moment today talking to this nurse practitioner because she was really down. And so what I'll start with is what I typically summarize with, which is that for those of you that have a therapist, call them. If you think you might benefit from talk therapy, find a way to engage in that. This is a time when people who struggle with any sorts of issues regarding depression or anxiety or substance use or interpersonal conflicts in their families are all at huge risk. So get help for yourself, look out for each other, and really above all, just do the right human thing, which is to have empathy and care about one another and start there.
Thank you. I think those are very wise words, and I wish it was easier to follow through on it. And I think that's what's so frustrating for many of us. You know, I haven't really, in some facilities, I haven't set foot because they are infested with COVID, and I have some naive facilities that I need to protect. And so I still do it, but it's the televisits, it's the telephone calls that I can only make. And I'm a very, very interactive person, so that's hard for me. But I think these are very, it's just being a human being, asking, not asking how people are doing, connecting with them as much as we can. But what I want to shift a little bit from that to what are more systemic responses on an organizational level, because we are also head of organizations. What can we do? We're head of organizations in our facilities. Sometimes in a bigger organization, we are part of AMDA. What can we do on that level to support positive outcomes for staff and for families? Kathy, why don't we start with you?
Okay, well, thank you very much, and thank you for this opportunity. I think that's an excellent question, and what I've got a couple of thoughts of what we are doing, and some thoughts of and actually some examples of what we're looking to continue or add to our repertoire. What we've done as an organization is try to emphasize communication and really work with the staff and the team and communicate on the education component. I love the focus on the trauma-informed care, the TIC, and the focus on safety. And what we have found that one of the biggest fears of staff is the fear of, am I going to be protected if I work on the COVID unit? And of course, some of the biggest challenges we've had have been in the arena of PPE. So we have, as many of us have, embarked on a very intensive, ongoing, repetitive PPE process in education, focus on safe use of PPE, and constantly analyze that. The other thing that we do is at the beginning of a shift, we actually huddle and talk about what does PPE look for this patient population on this unit today. And we've done that as a primer through all of our facilities, whether they're COVID positive or not, or COVID experienced or not. We're doing it definitely. We've learned that we need that huddle for the COVID unit. It's very critical that the staff have a chance to think through how does their day go, where do they need to put stuff before we start the COVID unit. And then once we absolutely have to have it, we walk through all processes and make sure that those processes make sense and that they're safe, and how we're going to exchange, how we're going to don and doff PPE, but how we're also going to exchange items that come and go out of the unit. We've really worked hard to make the staff area on the unit a comfortable area. In fact, our very first COVID unit, we brought in recliners, and I think you'll remember, Sabina, when we did this, and yes. it was actually it was a really nice model to start with, and we got some great feedback from the staff. We've also had to deal with those one-off scenarios. Oddly enough, we've had a couple of experiences where we've recruited staff members from hospitals who have worked in COVID units. And so it was probably 2 to 3 weeks into the process. Because we usually incentivize more on these COVID units, and so we were able to get some of the staff from the hospitals. We had some positive experiences with that, because many of those individuals came equipped with the technical skills of working with this population. We also had some challenges with that. And in fact, we actually had a nurse that almost suffered a PTSD moment when that person ended up working on a COVID unit and was not able to continue out a prescribed time period because it was so traumatic what he had witnessed in the hospital, which was a real reminder for all of us of the intensity of this experience.
Actually, I think that's a good follow-up question because I've seen that too, how different the staff actually reacts. Some people are just forging ahead and I got my PPE and I'm doing it and I'm full of admirations. And others are not that resilient and in fact are not able to do literally not able, do not feel able to do the work. And I don't know, Arif, whether you have seen that and how you have dealt with that in your role as Chief Medical Officer and clinical advisor to your patients and staff.
Yeah, so this is a very, very important topic, and thank you for having me here. And it's very intimidating to go after all you ladies. I mean, you all have made your mark in this field, and I know of it. So, I'll provide any pearls I can. So I just want to talk a little bit about, the silver lining. I always like to. I'm a little bit of an optimist, and like many of you, I don't try to focus too much on the negative of the pandemic, which we have. To deal with it, we have to deal with it, right? I mean, maybe that's my way of dealing with the anxiety and stress of the pandemic, is to try to shut out the negative and look at the positive. To me, the biggest silver lining of this pandemic has been that we are thinking about geriatric care, like really, really thinking about it, like we always should have done, right? I mean, think about teamwork, think about technology, think about interdisciplinary care, think about deprescribing, advanced care planning. I mean, this is what we're supposed to be doing forever, right? I mean, this is nothing new. I mean, this pandemic has just put things right in our face in a little bit more intensity. Same way, anxiety of the staff at the front line, burnout issues are nothing new. I mean, how many years we have looked at the data that provider burnout at the front line, doesn't matter if you're a nurse, you're a doctor, you're a nurse practitioner, your anxieties, your burnouts, your emotional exhaustion, your detachment, has consistently gone up, almost 50% or more. I mean, when would we really would have reacted to that in a real positive way? We just never took the opportunity. And then there was the issue of policies, and look, the waivers are coming through. So the environment was never more urgent, but also never more conducive for us to really provide the best geriatric care at the front line. And there's no geriatric care in the front line which can be complete without putting attention to how the team is doing. And the team is not just the frontline nurse or the CNA who's at the frontline 24/7. It's the doctor, it's the practitioners, it's the family members, right? It's the medical director. So how I think about it, I really try to, again, personally, that has been my passion on really to address these issues. And I mean, I've been studying these issues, and I think the most important thing which had to be done, and I'm seeing that move pretty quickly with the pandemic, is the organizational buy-in that the staff need more attention, right? I mean, I think we always needed that to begin with, but unfortunately it never became a priority. We were always victim of distraction in post-acute long-term care from the regulatory frameworks. Unfortunately, our regulatory frameworks actually act out to be a distraction for us. They always get the precedence. It's so hard for us to get to the meaty part of really geriatric care because we're just so much focused on regulatory frameworks. And I think well-being of the staff turned out to be one of those victims that we just never got to it as a priority. I'm not talking about everybody, I'm just talking about for the most part. That's why our numbers have been so terrible at the frontline care. But now I think finally with the pandemic, when things start hurting us personally as humans, we start changing our behavior. Now because we are worried about our own well-being, because this virus can attack us too, now this issue of well-being and understanding what staff are going through has become easier for us to see and for leaders to see. And I'm talking about policymakers, I'm talking about politicians, I'm talking about everybody in the room, right? So I think this is the time for us to seize the opportunity to highlight this issue because people are understanding and getting it better than ever. So I think it's a great opportunity for us to rise and shine. So I always put these well-being issues in different categories because it's very hard to address the well-being issue just by like, hey, we need to do a better job with well-being. No, I mean, everybody has different needs in this well-being spectrum. What do you do as a leader for your colleagues? What do you do for your administrative staff in the home office? What do you do for the nurses? What do you do for the family members? So you have to think about them very separately, and strategies, of course, are very interconnected. If you can do one thing well, which is teamwork, it helps everything, right? But again, that's not enough because every team member needs a different kind of attention. And I'll give you one example, right? I may not be that much in need of having a pantry in a nursing home, right? For bread, for basic day-to-day things like canned food and all those kind of things, which is really hard for our CNS to find in this time of pandemic, because either the grocery stores are closed, because they may not have enough money, because they have been quarantined for a while, or because when they go to the stores, people look at them like, oh, this person works in a nursing home, so that they don't like to go to the grocery store because they are tabooed, they're targeted in some ways, and that those are real stories I don't want to go into, but they're real stories why it's hard for staff to really go and be in the community. So having a pantry in a nursing home, which Signature has focused on quite a bit, so that staff by the end of the day when they're wrapping their shift up can go and grab some of the utility things which were important for them, so they don't have to swing by the grocery store at the end of their shift and so forth. So we really have to be very systematic in how we're addressing burnout issues. And most of them, as Kathy and Leah said, start with communication. We cannot get away if we as a healthcare leader are not investing in formal structures of regular conversation and making sure that people have absolute approach to easy information on what the heck COVID is. Forget about COVID. Before COVID, this should have happened, right? People should have had easy access to what antipsychotics are. Why the doctors are always telling me to cut them down? Or why my doctor is telling me not to send the patient to the hospital? Like, this lack of communication has been a big reason for well-being issues. And I think with COVID, we have seen that we cannot get away with it anymore, and we have to formalize it. So I hope that kind of adds some value to some excellent comments which are made by you guys.
Well, thank you for that. I love the idea of the pantry and meeting people at different needs and the trauma-informed care. Dr. Watson, do you have some exercises for us, maybe, and for some of us, this is the communication or the approach of people with trauma is easier than for others. Are there some exercises that you can think of, or some script, possibly even, that you can walk the staff through, talking about maybe trauma or resilience or fostering resiliency?
Sure. Let me just take a minute, if I may, to talk a little bit about a really important concept called moral distress. I think one of the things that has been so demoralizing about COVID is that we are all experiencing moral injury. This is a term that comes out of the military literature, but it essentially means that there's some transgression of our deeply held moral beliefs and expectations, where there's a betrayal of fairness, of safety, of organizational expectations that we did not choose, but nevertheless we find ourselves navigating. And so when that happens, and a perfect example is not having enough PPE, having to wear a raincoat, right? Or not being able to have enough staff to do the job that you're used to doing. And so it's a really big deal to experience moral distress. And for many people, it's the first time that they've really felt it. I think in the long-term care space, sadly, many of us have felt this in other ways because of the regulatory environment. But the outcome of moral distress is actually shame and guilt and anxiety and anger, and it can cause emotional numbing. So let me just first say, as some sort of exercise, is validating that your feelings are normal is the place to start. So knowing that the guilt that we feel, that Arif was talking about, for not necessarily being on the front lines, right in the trenches, that is normal, and there's a way to deal with that. One thing that's really universal when people are scared is that there's anxiety. So learning how to manage anxiety is something that we can talk about, and recognizing what an anxiety loop is. So I don't know about the rest of you, but I've done a fair amount of worrying over the last 3 months, and had some sleepless nights and some weird dreams. And we talked about this in a previous webinar, and just to know that that's normal, and to really try to focus on some basic mindfulness techniques, which means essentially staying in the present moment. So the brain is a fascinating thing. We tend to be rehearsing for future events or remembering past events, usually through a negative lens of something we think we did wrong, and then worrying about something that's going to happen in the future. So when we can stop ourselves and really identify what our worry is, often there's not anything going on in the exact present moment. So if we can just stop, this is called thought stopping. So anxiety we know is contagious, and when we attend to something, it actually grows. So we don't want to deepen the grooves of negative thinking. Ways to get out of that include engaging your senses. So let's just say you're feeling overwhelmed, having a crazy day. You're worried that your patient's going to die, then you're worried that you're going to die, and then you're worried that your kids are going to die, and that you're never going to have a job again. The whole thing starts going. You can really shift gears by doing something for one of your 5 senses. So hold an ice cube is a great technique that we actually teach patients, but we can all do this too until it melts, because it actually literally shifts the way that your brain is innervating to shift it to a sensory mechanism. To step outside and label the sounds that you hear. You can't simultaneously be engaging your senses and ruminating about an anxious thought at the same time. So that doesn't work. And fear, we know, is actually a very self-preserving mechanism that we have for fight or flight. Anxiety is actually a worry or dread in the absence of an imminent threat. So while COVID has been such a horrendous threat and has changed all of our lives, in every moment of every day, it's not happening to us. So we need to appreciate the good moments. We need to stop and recognize that no, right in this second, nothing bad is happening. And I can choose to see this as a stick and not a snake, sort of in the anxiety paradigm of thinking. So thought stopping the anxiety loop are 2 things you can absolutely do. Recognizing that you should not feel guilty or ashamed because you're feeling down and depressed and angry, that is very normal. And that actually getting help is the next best thing to do, both for yourself and for those around you, to acknowledge that those things are happening. So those are some clear things. And obviously the self-preservation things, I talk about a difference between self-preservation and self-care. You know, in the early days of this, it was about self-preservation because we were all working 24/7. That was when you really need to remind yourself to eat and to get a few hours of sleep and to at least walk outside once a day. Now we're into the longer haul, and you really need to develop a system of self-care, and that means scheduling pleasant activities. And by that, I mean whatever is important to you, make sure they get penciled into your schedule. Drop the guilt. Guilt helps no one. It sinks all ships. If you are in any sort of management position, keep normal hours and be a role model, because you are actually modeling that for the rest of your team. Take care of yourself. Don't be a martyr. Know that it's not good to stay at the bedside for 15 hours. Exercise. All these things we know, but we don't all do them. So get your heart rate up for 20 minutes at least every day. Take time to extend some positive habits. And again, if you feel yourself really getting low, really engage in getting yourself some help from a professional. And the daily huddles, I was very happy to hear Kathy talking about. What we miss the most in this strange world we're living in now is that we have no way to connect with each other and feel all of the good things that we love about going to work.
I know.
And so if you can have a huddle, even if you can't touch each other or hug each other or share, you know, donuts, you can at least go around the room and say what you're grateful for that day and share what was the best thing or the worst thing about your shift. And you can all feel like you're in it together. So that's a handful of things that I've seen work for people. Yeah, sorry, you didn't ask for that many, but.
No, there can never be enough of those kinds of tips and really tangible things, you know, being how to be a role model here and the huddles. I think that's a very good one. Kathy, maybe you want to talk a little bit about some of the other highlights, and Arif talked about opportunities, but talk about some highlights that we have experienced as caregivers or in our organization too, like the graduation ceremony, for example, that we really tell us about that and how much that meant to the staff, so that it's not all defeat but we see the beautiful moments in
Right. And those are some of them. It's been really very touching to see celebrate when residents actually recover. And so we have, in a number of the situations where we've had COVID units, we sort of line the halls, and practicing social distancing, of course, but the resident holds a sign that says, "I'm a COVID survivor," and they, depending on where they are, they'll play music, and just everyone claps and applauds and is just super supportive. And the residents just beam. So that's been a real positive. And then we've actually we've reopened several units, and that has been quite the moment because it's a culmination of all the emotions everyone's been speaking of, and the intensity of the process. Because I think that's the other piece that this presents is it's a highly intense and constant intense process, and that's all been positive. I think it has helped us focus more in on palliative care and being better prepared for palliative care moments, especially those very end of life, because as we all know, this particular disease poses a unique type of time frame and how the residents experience those times. I think it was an AMDA presentation from the AMDA conference this year that was just fabulous and really drove home the importance of being prepared with your narcotics and getting everyone prepared that you're going to need to support a lot of respiratory distress in some individuals at the end of life. That has been particularly difficult for staff to witness that. Not everyone goes through that, has been our experience anyway, but we have had a segment of our population that does experience some pretty significant respiratory distress and chooses not to go to the hospital. And so being better prepared for that has been a positive. And I think people feel more comfortable with helping to support individuals through that. Another piece that we're going to try is, because I still worry about the staff, these are their family members. They've been working with these residents for years in many cases. And so they're not only going through a scary time with an infectious disease process, but they're watching people they love go through it. And I think that our space in healthcare probably would benefit from more focus on bereavement processes for our staff. And so what we've done is we've reached out to a hospice to assist us in some virtual bereavement groups for the staff, because they are seeing, there's still a percentage of these individuals that don't make it through this course of the disease. So I think that's going to be a silver lining, Arif. I know you and I've worked together on some of that in the past as well. And so it's much easier said than done in many situations, but COVID has brought that to the forefront, is the importance of doing that.
Thank you, Kathy. Arif, do you have anything to add to that?
Sure. I mean, I would continue to push everyone on the call, all the listeners, that you all are leaders in post-acute long-term care and maybe other settings. So just don't get too much wrapped up, as I think Leah said, that this is a marathon, this is not a sprint. So use this opportunity to get out of the reactive mode, right? Yes, COVID hit us. Yes, staff were under distress. Yes, we needed to help them. But this is not about that. This is not just about, just forget about COVID for a second. What? And anything for a second, yes, that's okay. During that little walk, which Leah said you to take, forget about COVID for a second. And think about a world without a COVID, and think about what you should be doing to set proactive structures of well-being, right? It's rather easy to think reactively, right? We humans do really well. We get sick, we go to the doctor, natural thing, right? Somebody is crying, we want to console them. But when people are not crying, they're just stressed out, right? Or they're not yet at a point where they're going to be crying, right? So there's a whole lot that can be done for people before they get to a point where they're under too much distress. And that's the value of proactivity. And I would recommend everyone to think about, as a leader, how are you addressing these 5 things, which this my favorite JAMA paper on COVID is the one which came out in April. And I mentioned that in one of the previous web discussions was this paper on well-being. And it says that our staff need 5 things from us, okay? And believe me, we all are leaders. You may not be a CMO, but you're still a physician in that building. So there's people who kind of look up to you, and you need to give them 5 things, all right? So these are the 5 things they ask for you. Number 1, hear me, okay? You need to listen really well, all right? You have to have some process of surveying them, okay? So as a leader, if you're not surveying people formally or informally, you're missing out on what they have to say. It's not only when people start crying that you pay attention or start screaming or yelling. When people even are talking normally, you have to have some way of knowing like how much stress is there underneath them. Number 2, protect me. It's an absolute, even if somebody's not asking for protection, you need to be able to see and assess and ask them this question like, hey, you feel safe coming to work every day? And by the way, in the recent environment of these riots and this racial disparity, which has become so prominent, a lot of people, don't feel safe. I mean, my own personal experience, when I left, the country I used to be in and came over here, there was a certain time I didn't feel safe. And again, it was just in my mind, right? Whatever it was, there was some element of distress that I had. And it's important for us to proactively ask people about that. Number 3, prepare me. You need to teach me, train me so that doesn't matter, my job is very task oriented. Even if I have to remove PPE and put it from one room to the other, I still could do it better, all right? And if I know that I'm learning new techniques and somebody's teaching me to be better, man, I get more engaged with you and there's a less chance I'm gonna be distressed. I'm gonna feel this partnership. So make sure that you are investing in people's growth every single day. And again, this framework is important. I mean, mastery is important from any internal motivation framework, right? So we know that. Number 4, support me. Okay, I don't just need your advice. I just don't need your dollars. You don't have to give me hazard pay. But you know what? Speak on my behalf. Don't throw me under the bus in the press. Speak in the favor of all the hard work I'm doing. That's going to be way more important to me than your hazard pay you're paying. If you just say 2 things good about me today, that has way more value than you may paying me a few dollars extra. So support me. And last one is care for me. Don't just support me, but come and hold my hand when I need it, all right? So there's very good reasons that you're not on my bedside. Like, for example, as was said, that some physicians are not at the front line because of very good reasons, right? Sabine, because we don't want to spread infection. But if there's no good reason why you're not there, you should be there. We as physicians need to be at the front line unless there's some very specific good reason we're not there. So be there for me. So I think those are the 5 things, COVID or no COVID, we all have to have that framework. What as leaders we are doing to operationalize those 5 things. Because if we're not doing anything, guys, we are absolutely falling short of leadership at this point. So I think this is a good time for us to do an internal assessment. And I think it's a very good webinar today because Leah is talking very much about, and Kathy also is like what we can do personally to do good. And again, Kathy is talking about both those issues, like what organizations and leaders can do for others to be less stressed out, right?
I'd like to make a comment if I could, Sabine. I really appreciate all 5 of those. Those were excellent points. And what it brought to mind for me in witnessing several scenarios and obviously working very closely with Sabina in a number of those, it's the presence of the medical director and the involvement of the medical director can make huge differences as to how the facility and the facility staff respond to what's happening before them. Our situations where we have the most engaged medical directors, a partnership, and I would appeal to all the medical directors on the call. You can be a calming voice and a reassuring voice to bring that safety that Dr. Watson talked about to start with, and then all 5 of the elements that you just mentioned, Dr. Nazir, the role of that medical director has been very key. And you also can help that policy in the facility. And you can, even if you don't go back on the unit, if you support the administrator and especially that director of nursing on how to manage this, reinforce the processes that are in place on how to manage this, then they're calmer leaders. they're confident leaders. And so you can actually influence others to then influence what happens on the unit. And it's really been a very powerful difference when we see that involvement of the medical director, a very powerful difference.
Well, thank you for saying that. So as its chief medical officer, of course, I've taken that to heart and have tried to support my medical directors. So we used to have a once a month meeting, and ever since COVID, we have a once a week meeting where I try to really give up the latest up to date, whatever is moving us this week. That so that's something that that we can do. And I think our medical directors, I'm very grateful, have been very well prepared to help out our facilities. And I can tell that that is very helpful for facilities, and especially in the early days, the role of the medical director, and I've talked to many of you, I think has been, I have never felt as important in a way, not self-important, but as being able to make such a difference in calming people down, giving them the information, taking care of them, being available at all times. I think all those, I didn't know about all the 5, but I think that is, I like the framework, and it validates some of the things that we were able to do as medical directors. And I would love to see, moving forward, Arif, we were talking a little bit about AMDA being an organization that leads us, and that I personally draw a lot of resources from and have drawn a lot of resources from in this time. Get that framework more out there, and be pandemic and catastrophe prepared. I think we've done some of that. Off and on, you know, around, I think, some natural disasters when Katrina hit. But I think this is an opportunity, once again, to take that to the next level and really give that a little bit more focus and have it all ready to go, and really bring everything that we have learned from the last what seems like eons, but are really only 3 months, and bring that to the forefront and crystallize it and say, this is the role of the medical director and the team member, and work on that as an organization.
Yeah, I think this is, I mean, as the immediate past president, I mean, I may have a bias in saying this, but my honest opinion is that I will give AMDA high marks on how AMDA has performed. And when I say AMDA, I really include chapters. I mean, you know, what Washington had done, California. I mean, there's just some chapters who have been like at the forefront of just unbelievable, tireless work. So I give AMDA, you know, as an organization, high marks. But I'm not saying that there's no room for improvement. I think what has given me the know-how is like, you know what, nobody was ready for this pandemic. And we did what we could, and we put resources together. We patched up things pretty quickly. And I think we're quite successful in hitting those 5 things for our members. Hearing them, protecting them, caring for them, supporting them. I think we did hit all those things, but I think we could have done it way faster. So I think one epiphany for that has been, for me, as the past president of the organization, is like, what if AMDA had a pandemic preparedness plan already ready on the shelf, right? You know, so I think that's going to be a learning for us. There has to be a lot of reflection that will be going in, and really already in the board meetings, you know, we already are having a conversation. Is like how AMDA could have done a better job, or any organization for that matter could do a better job. And it could be your organization, Sabine and Kathy, it could be Signature Healthcare. We all have had a better understanding. And of course, nobody can blame us. This is the first ever pandemic in 100 years. So nobody other than CMS maybe sometimes can blame people for not going, for being perfect, but I'm not going to blame anybody for not being perfect, because nobody had the information of how this is going to play out, what impact it's going to have on people. You know, we all are learning on the go. So we have learned a lot. And I think AMDA has our work cut out for us to really make sure that, God forbid, if something like this happens again, that we will be way ready than we were. And then really taking care of the frontline staff and our members is going to be one of the top agenda items in that preparedness plan.
Thank you. Yeah, I didn't mean to criticize AMDA at all. I think AMDA has been a great resource.
No, you didn't criticize it at all. I didn't see that at all.
Yeah, but I think, and just as we felt supported by AMDA, and that I could always go on the website there and find things. That's how we need to be. That needs to be translating down. That was our experience, and we need to give that experience to the people that we lead, and may it be just a unit or a facility or 3 facilities or 50 facilities. That's our responsibility to give others the same experience that we have had from AMDA. And yes, we should have all had the pandemic plan down, but we didn't. But we did our best, and I think as the pandemic moves forward, we will continue to do our best. And I think one of the things, when we talk about Hear Me, I think we have to hear each other and see what can we do better. I mean, I'm a big QAPI believer. So what did go well and what can be.
And quickly, Sabine, I just want to, sorry to interrupt, but I want to give a shout out to experts like Leah. I mean, we invited Leah, Signature Healthcare, to talk about what our medical directors were going through. And I think it was one of the best things we have done for our medical directors, among many things we have done for them, was to have them, give them the opportunity of knowing that they're not alone, that the guilt they're feeling is okay, and there's ways they can kind of, so Leah was very helpful to Signature, and those are the resources which AMDA can make easily available in the future. I wish there were like 10 Leahs who could be engaged with AMDA members and with CMOs and really addressing this. So I think that's one thing which AMDA could take a lesson from, is to have those resources ready. I don't know, Leah, you have something to say. I mean, can you clone yourself, for example?
Yes, please. Give a comment on that.
I don't think that's possible yet. But one of the things I did want to say is that it's really important to ritualize and honor those that have passed and those that are sick. I think the speed with which some people have died has been mind-boggling, at least in my community. I mean, I've gotten on calls. I'm on a monthly call on about 30 different facilities. And in 1 month, 16 people have died and 2 staff members are in the hospital. And so one of the things we've been trying to do is to create some sort of ritual way of honoring that loss. And it's not only the right human kind thing to do, it actually helps mitigate your trauma response, to have some closure and to really take notice and not let one person die without knowing that they were remembered. And one of the ways I've seen that operationalized in some local facilities is they'll do something as simple as put out a table, not sort of like an altar. It's very religious or whatever religious or faith you want to bring to it, but a place that people can leave notes and pictures. It can be anonymous. It allows staff members to write a message or to leave it there, or to bring flowers, or just some way to honor and to not let one life be lost without there being some ritual to honor that person, whether it's a family member or a patient or a staff member. And that, doing that as a leader, it's very, very powerful to watch your medical director go up and leave a card and a flower on a table when a resident died last night. It means a huge amount to staff and to family to see that someone in that leadership position is taking that so seriously and personally, and it brings a lot of comfort to people.
Yeah, I think we all have been bereaved in our lives, and I think the ritual of bereavements are adding a lot to dealing with the grief. So I think that's a beautiful picture, and I think, Kathy, let's talk about what we can do there if we haven't done it already. Yeah.
Sabine, I do want to ask if you wanted to share the experience that you had in one of the Seattle facilities with the resident who was Korean.
Yes. So I think so I think that, and again, this was an opportunity for the staff, and it was healing for the staff and for the family. So we had a lot of closures in our Seattle area, and one of the facilities that closed was a Asian facility, and the Issachar facility, which was the second nursing home in the country who had COVID, had given opportunities for those residents to move to them. And we had a Korean patient that had been cognitively impaired, and she was one of our earliest COVID victims. And of course, the family couldn't attend during that time. But what the family did say was that they really wanted her laid out in Korean garb. And they brought her Korean costumes over, and the staff spent a lot of time giving her the appropriate attire. And then there was a televisit, if you will, with the patient's family, and they were able to say goodbye to her in a culturally very meaningful way. And I think it's that really, it was healing for the family, but it was also healing for the staff. I mean, I think if we allow the staff also to be caring, and if we give them the time and the opportunity, and then if we acknowledge it, and there was a lot of acknowledgement around that later, I think it did a lot to soothe the staff, who was quite traumatized at that facility. We also did then have a professional later on. We had a professional come and speak to the staff, because this facility was quite traumatized, and we learned a lot in this facility that we didn't know, and really the way the COVID exploded in this facility. We didn't know about pre-symptomatic, asymptomatic spreading. We learned it all there. So I think there is a lot to be said around the bereavement rituals that can heal both the family as well as the staff, which in fact is also the family. So thank you for giving me the opportunity to talk about that.
Yes, I think that was really important, and based on the sharing that you had done with that, another one of our facilities actually had a resident who was passing and who was of a Buddhist orientation. And so we were fortunate to have him close to a window. The room he was in had a window to the outside. So family members were able to set up altars and go through traditional religious practices. And he was able to hear that through the phone. And so really honoring those cultural traditions can be extremely healing and so reassuring during one of the most difficult times. I think that's probably been one of the biggest challenges of COVID, is the inability for even family to be safely close to the resident. And I think that our staff, the positives, to go back to your point, Dr. Nazir, the positives here are that people are more now, I think, are more sensitive to the needs at the end of life. And we are having to think through, what are we going to do to not only support the resident, but also support the staff. As an organization, one of our support mechanisms is we have a very systematic process, especially at the initial outset of the COVID unit development, where we get on and we partner together closely, and we walk through a number of task items. But woven into those discussions are the questions: how's the staff doing with this? What are we doing about this person's end-of-life experience? Is there something more we need to be considering? And having prompts worked into that process to help us stay focused. Because the other challenge, of course, is from a clinical standpoint, we can become very task-oriented. And there's a lot of tasks to get done, especially in this kind of scenario. So we've tried to weave that in. The flip side is also we've orchestrated a staffing ratio on these units that do allow for more of that personal emotional support for the residents, because it is such a scary time for them. And to be able to allow for the telecommunication with family members and close people who they are close to, that they want to have important conversations with. So we do try to orchestrate that, and and it has the silver lining is that the staffing ratios have been such that the staff actually do have more time to be able to do that, which is a take-home message for us as leaders, that for us to consider as we go forward. And some other conversations I've had is that this process is emphasize the importance of really looking at the model of care that we're using. In our traditional world, back to what Dr. Nazir was saying, that we have to think bigger than this. What are the lessons we're learning from COVID that actually apply to the bigger world, and the lessons that we need to take home? And I think one of our big challenges is the model of care. The biggest challenge that I have found in this entire scenario is I love person-centered care. I want us all to get to where we can give person-centered care, but it can be very difficult to do that on a good day. And then you add an intense infection control and prevention practice, and it's very difficult to make this personalized and home-like environment. I really feel like that would be an excellent initiative for several of us to engage in the discussion. How do we continue to give personalized home-like care in a home-like environment and honor infection control and prevention principles? And it's very difficult because they're not really juxtapositioned very well. So
one thing I would say to that is, as physicians and practitioners on the call and leaders, cut out all those unnecessary steps that never had any value, and we were doing them anyways because of inertia, right? So think about all the medications we're giving to our patients which are not needed. Think about all the nebulizers that have gone and become history.
Nebulizers, yes.
So think about so many. I bet you that's just tip of the iceberg. Think about the iceberg that you can cut out from the unnecessary hassle for our frontline staff, so that they can have more time to do things which are more meaningful, which is connecting with their patient and family. So I think that's the big role we as leaders and providers and practitioners have to play, is to free up the time for our frontline so that they can do the more meaningful work, and then they can feel less anxiety and feel more useful.
Can I also jump in quickly, Sabine? I know we're running out, but I really want to urge all of us, especially leaders that have some power to make change, to really, truly, urgently push the envelope on liberalizing visitation, on liberalizing activities. I think that we have learned how to use our PPE, where our infection control understanding has dramatically improved over 3 months. And we are truly about to experience a second crisis of isolation and depression. I'm seeing it every day, and deconditioning. So we've gone over the rules very carefully, and there's a lot of wiggle room if you do them correctly and creatively and thoughtfully. And I really challenge you all to push the envelope on resuming visitation and activities.
Well, that's a good challenge for us. It's one that we're certainly going to have a lot to bite on, especially since we are being traumatized for when we didn't have that, and when we saw so many of our patients die. But thank you for reminding us of that. I think it's something that we're all touched by. And even if our patients do not have COVID, they are all affected by the very strict measures that we had to put in place. They may not be infected, but they are affected. So thank you for that reminder, Leah. And with that, I want to thank everyone to participate in this important discussion. I think there were many good impulses, and some of the parts is the 5-part approach to proactive well-being, organizational impulses such as the huddles, the enforced 10-minute break, leadership that we can exert by modeling on good practices of well-being, and enabling those in the people that we do lead, transparency. The list goes on and on. Thank you for giving us this gift of better preparedness to take care of our staff as much as we take care of our patients. So thank you. AMDA will continue COVID Grand Rounds as a peer-to-peer discussion, bringing you topics of greatest interest and up-to-date information as it specifically relates to our patients in the COVID pandemic. If you have any suggestions for a topic you'd like us to cover, please email us. And I would also like you to know that this session has been recorded and will be added to the AMDA website. And you will be getting a link to the AMDA website. We will see you again. I think I've never meant it more when I said be well. All right, bye-bye.
That was excellent, Sabina. Thank you.
Absolutely excellent.
Thank you, guys.
Thank you.